for you today. And I would like to invite Dr. Debulal Chakraborty. And Dr. Chakraborty, I hand over this platform to you now.
Thank you so much. I'd like to thank AIOC for this kind opportunity, and I'd like to thank Mr. Hime for, helping us out. So we will just, start off with the introduction, and I'll be sharing my slides, the introductory slides. I am thankful to my co-speakers who are here, co-instructors who are here today. So I will be speaking on vitrectomy in difficult scenarios, how to handle. So this is going to be an intermediate course, and especially for people who've done their fellowship and are in vitreoretinal practice for a while. And then, there are some small issues that we come across in during vitreoretinal surgery. So this is what this will be all about. So we have a galaxy of stars here. And just to introduce the speakers, we have Dr. Manav Jyoti Burman, who is going to be the first speaker. He is Senior Consultant and Head of Retina Services at Sri Shankardeva Netralaya, Guwahati. He is an active academician, and he is a thesis guide to many of the PGs, and he looks after the fellows there, many publications in peer-reviewed journals, a PI in many trials, and actively involved in academics. The next speaker will be Dr. Aniruddha Maiti. He needs actually no introduction. He's a senior vitreoretina consultant and HOD at Shushruth Eye Foundation and Research Center. Has more than 150 presentations in national and international conferences, and he has published more than 20 research papers in peer-reviewed international and national journals. He is presently the Joint Secretary of the Ophthalmological Society of West Bengal and the Scientific Committee Chairman of the Vitreoretinal Society of West Bengal. Our next speaker is Dr. Arindam Chakravarti, a senior consultant of VR and UVA services from the Center for Sight, New Delhi. He also needs no introduction. He has 18 years of experience. He did his MBBS from Guwahati Medical College and MS from SN Medical College at Agra. And following this, he did his VR fellowship from the famed Shankara Netralaya in Chennai, and he has 8 publications in index journals, and he's also an active academician and has a host of presentations, national and international. Our next speaker again needs no introduction, Dr. Shubhendu Boral, friend, philosopher, and guide. Well, he's a senior VR consultant at Disha Eye Hospitals, and he actually didn't, want me to say anything further, being so modest. But just to, give a perspective, he's an author of, books, especially the Video Atlas of Vitreoretinal Surgery, many publications, many presentations, India and abroad. Lots of awards. He hasn't named any, but I personally know he's winner of many awards, and he's a PI with many trials, and known for his work, exclusive work on vitreoretinal disease and surgery. Dr. Rupak Kanti Biswas, again a luminary who needs no introduction. He's a senior VR surgeon and director at Netralayam, Kolkata, and he was the first surgeon to perform ROP surgeries in Kolkata. Has performed more than 8,000 complicated retinal surgeries. And he has established multiple new VR units in different hospitals in Eastern India. And he is also the recipient of the prestigious Red Buckler Award from ASRS and the Best Film Award from URetina, FIFA Award from AIOS, just to name a few. And he's also the serving Joint Secretary of Ophthalmological Society of West Bengal. And Dr. Manish Bapaye, another luminary, again needs no introduction at all, but just to take things forward. He won the K. Vasant Madhavan Gold Medal for the best DNB student at Shankara Netralaya in 2003. He is well known the world over for his innovation, the Claw, a novel IOFB forceps that many of us are using. And he's won the Rakesh Sharma Memorial Award at the trauma session at the AIOC Coimbatore in 2018, followed by the S. Natarajan Award in 2019, the All India conference, and also the Jailbreaker King Award in the Jailbreaker session at the VRSI annual meet in 2020. He has over 100 presentations in national and international conferences and 6 publications in various peer-reviewed journals. And I am Dr. Debulal Chakravarti, and I work as a senior consultant at Disha Eye Hospitals, and we'll take this forward. So I'll be asking Dr. Manav Jyoti Burman to present first up. So I'll just stop sharing.
Sorry to disturb you, Dr. Chakravarti.
Yeah.
You introduce yourself very little. You have introduced yourself very little. I know who you are.
No, thank you so much, sir. Thank you so much. So, Dr. Manavjyoti, are you there?
Yes, thank you, Dr. Devdulal. Thank you for giving me the opportunity to be part of this IC and also the scientific committee of AIOC. So I'm just going to share my slides. Yeah, can you see the slides?
Yes, please carry on.
Yes.
Okay.
Yes.
Okay. So good afternoon. So I'm going to speak on the complicated retinal detachment. So this is the first talk, and it always is little difficult to start with the first talk. Anyway, so I will just give the highlight of overall the complicated scenarios of retinal detachment, particularly rhegmatogenous retinal detachment. So retinal detachment affect around 0.6 to 1.8 million people per year, 8 people per year per 10,000 population. And over the early 20th century, the prognosis of retinal detachment was very poor and no effective treatment were available. And by last 200 years, maybe 2 centuries, there was a evolution of retinal detachment surgery. And by the last 50 years, maybe we can see the highest change in the retinal detachment management scenario. And by 2008, around 95% of cases of retinal detachment could be repaired successfully. And that was previously a blinding condition. So usually when we speak about retinal detachment, we can expect a scenario like this, and we all retinal surgeons are very happy to see a retinal detachment of this, which can be managed so easily. But all the situations are not the same, and sometimes we come to some complicated scenarios. Then what is a complicated retinal detachment? There is no any book definition I could find actually. So it is quite a subjective for the surgeons maybe. But it depends on certain factors like duration of the retinal detachment, etiology of the retinal detachment, and anatomical condition of the eye. I think the three factors contribute to complicated retinal detachment conditions. So number one condition is maybe the proliferative vitreoretinopathy. It occurs around 5 to 10% of rhegmatogenous retinal detachment. This condition depends upon certain factors like the presence of a posterior vitreous detachment, longer duration of the retinal detachment, greater physical extent of the detachment, associated vitreous hemorrhage, intraocular inflammation, previous surgery, and increased retinal tear size, especially in case of giant retinal tear. These are the conditions that predispose to proliferative vitreoretinopathy. So surgical management of PVR may require extensive peeling of membranes. A 4-port approach for bimanual dissection of membranes may be helpful in extensive PVR cases. And a soft cell technique where you can use viscoelastic material over the detached retina may be helpful in certain situations. And partially fluorinated alkanes have been tried with where in very bad cases where this can be these are heavier than siliconol and they rest over the retina in the lower part of the retina. And we can, in certain situations, we can leave perfluorocarbon liquid for 2 to 3 weeks and followed by a second procedure to remove the perfluorocarbon. These are the conditions that we can follow to manage PVR, very bad PVR cases. Then coming to the next condition, the traumatic rhegmatogenous retinal detachment, approximately 29% of patients with open globe injury are associated with rhegmatogenous retinal detachment. And this condition is worsened by the breakdown of blood retinal barrier that can accelerate the intraocular inflammatory process. Corneal scarring may impair visualization of the inner side of the eye, and often the associated iris defect or an aphakia may present challenges for the placement of a tamponade, and associated intraocular foreign body may further complicate the surgical process. So that corneal opacity, how we can manage this impedes observation of the fundus. So two options we have: temporary keratoprosthesis or endoscopy. So endoscopy provides a narrower field of view at low resolution and hinders patient management in the postoperative period. So PK with temporary keratoprosthesis may have some advantage in this situation. So this is how you can put a temporary keratoprosthesis and manage associated retinal detachment. So this in selective cases we find helpful to complete the surgery and also in the follow-up of the patients. So next is FAQ with RS defect. So management of silicon oil is often challenging. Silicon oil can migrate into the anterior chamber and can cause keratopathy, elevated intraocular pressure, and a suboptimal oil fill. So in these situations, we can use silicon oil retention system. So how to place the silicon oil retention choosers? We can just make two scleral flaps in opposite directions, and we can pass the 10-0 proline in crisscross fashion and make a barrier to prevent the silicon oil to coming to the anterior chamber and to coming in contact with the cornea. So this is quite an effective procedure in managing those FAQ and anorexia cases. Next condition is retinal detachment associated with intraocular foreign body. 40% of ocular injuries may be associated with intraocular foreign body. It can be complicated by retinal detachment, incarceration of the retina, endophthalmitis, and with often sometimes with metallosis also. So surgical management is always unpredictable, and a late onset of retinal detachment may occur following successful removal of the foreign body also. So this is what is a scenario we can see in retinal detachment associated with intraocular foreign body. You can see the incursion of the retina to the periphery anterior that was that we had to extensively cut. We had to remove the foreign body, and subsequently we had to manage the case as a giant retinal tear. So next is a giant retinal tear. Around 1.5% of retinal detachment may be associated with a giant retinal tear. So innovation of PFCL and its use has increased the primary attachment rate from 58% to around 94% in giant retinal tear management. And there are certain pearls in the management of GRT that include trimming the edge of the tear, identifying the breaks, all the breaks, and injecting PFCL regularly as a single bubble, and removing all anterior fluid by drying the edges of the break thoroughly to prevent slippage of the flap. So these are the basic pearls that we can follow to manage the giant retinal tear. So RD associated macular hole, I think we have a talk also on RD management of macular holes. I'm not going to speak a lot. So prevalence of macular hole coexists with a thought to be around 2% to 8% cases. ILM peeling of our detached retina using a pinch and peel technique is often helpful. In use PFC small to proper contraction of our retina also. So this is how we can peel the ILM over a detached retina also. And of course, ILM peeling is not a mass procedure in case of RD associated ILM macular hole, but if we can do, usually the visual outcome is better. So next is this is how a big retinal macular hole can be managed with macular with RD can be managed, and you can see a nice hole in the postoperative period. So RD with inflammatory processes and infection can also complicate retinal detachment, often accompanied by pre and postoperative proliferative vitreoretinopathy, and significantly higher failure and complication rates because of the association of multiple holes in the periphery and a very thin and fragile retina, and concomitant anterior and posterior segment problems.
One more minute, please. One more minute.
Okay, so you can see there are certain situations like cystic sarca cyst that can be associated with retinal detachment. So we can remove a cystic sarca cyst going to the vitreous cavity intake without disturbing the cyst, and also we can manage the retinal detachment. So this is how we can pull out the cystic sarca cyst with a cryoprop from the vitreous cavity. So certain conditions of pediatric retinal detachment are also very complicated. Pediatric retinal detachments are often complex. Multiple procedures may be necessary. It differs from adult detachment in etiology, anatomical characteristics, and management and prognosis. Appropriate preoperative evaluation of the patient and counseling of the parents is crucial. So one condition is ROP that is not included in the retinopathy, but rather a fractional condition which is very challenging situation that we nowadays we face. Though with proper screening of the ROP cases, nowadays the incidence is becoming slightly less. So entry site should be part of the canal. Lens is larger and papillary dilatation is poor. PVD cannot be acid easily. Breaks are extremely poorly tolerated, and cyclitic and papillary membranes are common. Subretinal hemorrhage, integration, and retinal pigment epithelia degeneration may preclude the favorable function outcomes. So
Doctor,
I think about one of those slides.
Dr. Barban, can we request you to please go to the concluding slide? Thank you.
Yes. So RD with coloboma is another condition. Difficulty to detection of that break and lack of pigmentation at the site of the coloboma. Retinal break may be within the coloboma or at the edge of the coloboma zone, or otherwise in the retinal area of the coloboma. If no breaks could be found, preoperative early post perform laser burns around the coloboma. So this is another condition, nanophthalmos, that I am not going to discuss too much. That is executive. So PDR also there's a job that is to discuss. So in summary, in the past 2 decades, the introduction of perfluorocarbon liquid, wide-angle viewing systems, and micro-incision vitrectomy surgery has improved outcome of complicated retinal detachments. So the most important part on the part of the surgeon is the proper diagnosis and surgical planning. That is the most important part that we should follow. Thank you.
Thank you so much, Dr. Manavjyoti Burman, for this illuminating talk. I will actually ask Dr. Aniruddha Maiti to speak on PDR with complex tractional detachments. May I request the hall coordinator to set the time at 8 minutes, please, because that's how it's been divided, and we will have the discussion at the end.
Absolutely, sir. We'll change it to 8 minutes. Timer 8 minute पे set किया जाए, please.
Thank you, Dr. Chakraborty, for giving me this opportunity, and obviously AIOS for selecting our IC. Well, I will be speaking on the management of complex diabetic TRDs, how we go ahead. We'll start with the simpler cases. This is one of the vitreous hemorrhage with a tractional detachment, obviously not a very extensive one. What we need to keep in mind, we should never force a PVD. And there are different techniques of membrane removal. It might be segmentation, delamination, or a peeling. The peeling can be through a forceps, picks, or a spatula. Here there was a very small membrane we picked up with a forceps. But preferably the use of forceps and pick should be avoided. And once we get rid of all the membranes, we need to do a meticulous laser to prevent the rebleeding. Now, coming to the next case, why we don't like to use the forceps. This is an example. This is vitreous hemorrhage along with the fractional retinal detachment. Now we can say after clearing the hemorrhage, we can see a tractional detachment on the nasal side. Generally, the nasal TRDs are bad. With a cutter, we are trying to remove the membrane, trying to delaminate it, but it's quite badly stuck with the underlying retina. So use the forceps. Yes, with the forceps, the membrane did come off, but it caused an iatrogenic break. So preferably in all cases, we need to avoid using the forceps. So once we have picked up the membrane, we should cut it off with a cutter, and we need to see whether there is any residual membrane. We should be pretty much sure that there is no membrane, and then do a laser. The mainstay of the dissection of membranes are segmentation and delamination, rather than picking up with the forceps. You can see the posterior pole, the entire posterior pole with a tractional detachment, the tabletop detachment. And we are not inducing a forceful PVD. We are trying to locate the plane through which the dissection can be done. Here we have identified the plane. We are lifting, very gently lifting the membrane with the cutter itself. And then along with the contour of the eyeball, we are doing a conformal cutter delamination. Now with a smaller gauge, this is quite easily done with a 25 and 27 gauge vitrectomy system. You can see we are gradually picking up the membrane. And so once we are sure that it is quite, it's lifted up from the retina, then we go ahead with the dissection. And then we put the triamcinolone acetate, remove the residual vitreous. In some cases, we do need to do an ILM peeling. In this case, I did an ILM peeling because there was a little bit of puckering in the posterior pole after removal of the membrane. ILM peeling in the diabetic cases, TRD cases are difficult. Now, bimanual dissection, this is a procedure which we used to do previously quite a lot. Nowadays, with the development of the newer innovative instrumentation and smaller gauge system, we can do without a bimanual dissection. The basic thing is we need to have a chandeliers light and need to lift up the membranes with the forceps and with the curved scissors. We have to dissect from the surface of the retina. We need to give small snips with the scissors, and it can be an inside out delamination or the opposite, vice versa. Once we have removed the entire membrane, removed by the cutter, the bleeders are secured by diathermy and the laser is done with oil injection. Now, this is one of the methods that is a proportional reflux, what we use nowadays to avoid the bimanual dissection. Although in some cases we do need a bimanual dissection. So this is a feature which is in the newer machines where we can put some fluid in between the membrane and the retina and create a plane. You can see in the animation, the plane. Once the plane is created with the cutter, we can first segment out the areas of the membrane, and then following that, we can do a delamination. Here you can see the plane has been created. The cutter is insinuated inside the membrane, under the membrane, and then it is cut and segmented. And once the segmentation is done, we can do a fold back cutter delamination. Now, once we get rid of all the membranes, the bleeders are secured with the diathermy, and then a laser is done. Coming to another scenario, the last scenario, it's a combined retinal detachment, fractional detachment leading to a rig. So dealing with the combined detachments are very difficult at times. We need to be very careful in trimming in performing the vitrectomy, because forceful PVD is it should be avoided. You can see the posterior highlight is very thickly attached, strongly attached with underlying. This is the last video. And then you mark the bricks, put some PFCL to stabilize the posterior pole so that we can do the peripheral vitrectomy. Yeah, we are doing the vitrectomy and the fluid is coming out through the break. Taking off the PFCL. And then draining as an regmetrogenous RD. Obviously, the laser should be done around the bricks as well as the PRP should be done because it's a diabetic case. it's done. So to conclude, obviously with the the newer machines and better visibility and a rational approach to the wide varieties of these techniques, not only improves the quality of the surgery, also give an better prognosis to these difficult cases. Thank you.
Thank you so much, Dr. Aniruddha Maiti, for this illuminating and beautiful presentation with beautiful, wonderful videos. So we'll have the discussion, like I mentioned at the end. So the next speaker will be Dr. Arindam Chakravarti, Senior Consultant at CFS in New Delhi. So he will be speaking on vitreous hemorrhage, the not so easy ones.
Thank
Welcome,
you.
Dr. Arindam.
Thank you, Dr. Debulal. Thanks for giving me this opportunity in your IC. Are my slides visible?
Yes, yes. Please proceed.
Okay. So I'll straight away come to the topic of vitreous hemorrhage. The initial workup obviously includes the routine history taking regarding history of trauma, systemic disease, besides the onset and duration. Slit lamp examination is important from the view of the media, because corneal diseases or cataract can hamper surgery. So certain cases in which cataract is extremely dense, we may have to do a combined surgery or a two-stage surgery. Blood staining of the posterior capsule is important to note, because that may lead to difficulties in removal of the posterior of the anterior hyaloid. There is a chance of lens touch. Neovascularization of the iris and the angle should be noted, because they can create issues during the surgery by causing excessive bleeding unless preoperatively treated with anti-VEGFs. Dilated evaluation of the other eye may give us a clue to the history or to the etiology of the vitreous hemorrhage. Like the other eye may show features of PDR or vasculitis, as shown in this picture. The mechanisms of vitreous hemorrhage are abnormal vessels, as in diabetic retinopathy, NV due to RVOs, sickle cell retinopathy, and rupture of normal vessels, as in retinal tears, trauma, PVD with retinal tears, retinal detachments, and Turson syndrome. And blood can come from an adjacent source like macroaneurysms or ARMD. Timing, of course, is urgent if there is associated RD or neovascularization. But in other cases, we can wait from a period of 1 to 3 months. The ultrasound is a very important investigative tool, because it gives us a clue of what lies beneath. So it indicates the presence or absence of an RD, of a TRD, of a CD, a mass lesion, or ARMD, especially the PCV variety. It helps in surgical selection and planning the surgical procedure, and it also helps us in avoiding surgery in certain cases where the prognosis is extremely poor, as in closed funnel RDs associated with VTIM. The recent hemorrhage that is diffuse and light may be acoustically clear, although it completely may obscure the view of the fundus. PVDs can be complete or incomplete. An incomplete PVD can have single or multiple vitreoretinal adhesions. Contraction of the membranes lead to TRDs, and due to contraction of fibrous tissue along the detached posterior hyaloid. Post-vitrectomized eyes with vitreous hemorrhage may show low reflective dot echoes. An absence of PVD in young patients and post-traumatic vitreous hemorrhage is important to note, because PVD induction may be quite difficult. So this is an example of a easy, fairly easy case where there is a near complete PVD with vitreous hemorrhage. But here, certain cases, we may anticipate difficulties based on the ultrasonographic picture. Like this gentleman had come with a vitreous hemorrhage with a inferior RD with a big tear here. And this patient also had dense cataract and was a post-LASIK eye. So we had to go for combined surgery. The cornea clouded up after cataract surgery. Corneal epithelial removal had to be done. Had to be avoided, as it was likely to disturb the flap. The poor visualization led to an intra-op bleed from the retinotomy, unfortunately. And post-op, of course, the patient had 636 vision and the retina was attached, but we have this bleed here. So the other conditions where surgical difficulties may be anticipated are vitreous hemorrhage with TRD, like this patient had undergone complicated cataract surgery elsewhere. The fundus was not visible and there was a TRD. This ultrasound depicts a tabletop TRD with a vitreous hemorrhage. This is another case operated elsewhere for cataract with vitreous hemorrhage. Now the previous surgeon hasn't removed the posterior hyaloid, and it is possibly caused the combined RD, and he also has vitreous hemorrhage. So this scenarios indicate that the resurgery will be extremely difficult, because persisting posterior hyaloid is a condition where it precipitates extensive PVR changes. Other issues during the surgery could be suprachoroidal or subretinal placement of infusion due to poor visualization. So always make sure that the tip of the trocar is well visualized. Alternatively, 6 mm infusion or anterior chamber infusion line may be considered. Loss of visualization due to bleeding, corneal edema, dense cataract, or condensation on the lens implant can happen. Good intraocular diathermy is essential when bleeding vessel is noted. Elevation of IOP is necessary. Alternative approaches should be considered in cases of loss of visualization. Sticky plastered vitreous, absence of PVD, especially in diabetic vitrectomies, can be any surgeon's nightmare. So here we have a case of PCV, which has bled. So there is an old vitreous hemorrhage. You can see how the heme appears. It's old heme. The cutter is used to do a core vitrectomy. The retina is visible. The hemorrhagic PEDs are becoming visible. The vitreous is cut till the periphery. You can see the hemorrhagic PEDs there. So the posterior hyaloid looks very thick, and it is plastered to the retina almost. Creating a plane is very difficult sometimes in such cases. Here it is being induced by suction, and you have to be very careful in this tape, as there is a high likelihood of break formation. The PVD is gradually being extended by suction only. The posterior hyaloid face is coming up as a single sheet. It's done very slowly, very meticulously. And you can see the sheet is up now. Finally, once the entire sheet is engaged and is off the retina, you have a complete PVD. Then the cutter is activated, and this entire sheet is removed. Fluid air exchange is performed. Now here we have a post hemorrhage removal, a bad diabetic, bad membranes. That's a fibroproliferative sheath, and it is being slowly peeled off. The vitreous is cut around the sheet. Dissection is done. A curved scissors is used to dissect the membrane close to the vascular proliferations. There is a high risk of intraocular bleeding in this procedure. You can see it is slowly removed, taking care not to cause any breaks. The vitreous should be completely removed in such cases. Now again, there is an adhesion with a with a very big blood vessel behind. The cutter is used first to create a plane. When it fails, then a bent 25 gauge needle is used. One last minute. The membrane is slowly peeled off. This is followed by a laser. There is a ooze coming, which we should be very careful. It is controlled with raising the bottle height. And this is another very bad case. This is the last case I'd like to show. You can see there is a vitreous hemorrhage densely adherent to the retina behind, which is detached. And again, extensive meticulous dissection has to be carried out with the instruments, with the scissors, with the cutter to create a plane. Creating a plane is extremely difficult because of the extensive PVR here. Finally, the adhesion is broken towards the end. So, what at the expense of creating a break behind. This I will skip. I'd just like to conclude that every VR surgery is ultimately a journey into the unknown. The wise surgeon is one who knows this and knows his or her boundaries. Thank you so much.
Beautifully demonstrated, and I especially like the ultrasonographies that you actually so beautifully showed. We'll get back to the discussion later, and thanks, Dr. Arindam, so much.
Thank you so much.
So our next speaker will be Dr. Shubhendu Boral, who will be speaking about vitrectomy in wet AMD. This is, I know it's his personal, area of interest, and he has a lot of presentations as well as publications. Welcome, Dr. Shubhendu Boral. You are muted.
Hello, can you hear me?
Yes, yes, yes.
Yes, yes. So, vitrectomy in wet AMD patients, when and how to proceed. This is my topic. Thank you, Dr. Debdullah Chakraborty, for inviting, for giving me the chance to talk on your IC, and thanks to AIOS for organizing our IC. So, vitrectomy in wet AMD. So, usually the subretinal hemorrhage, it is the main reason for which we are doing the vitrectomy in wet AMD patients. The other causes of subretinal hemorrhage, the AMD, PCV, macroaneurysms, trauma, and blood dyscrasias. Out of these 5 causes, AMD and PCV also almost goes hand in hand in principle for the principal cause of subretinal hemorrhage. So usually the prognosis of submacular hemorrhage is poor because of this barrier effect, toxicity of the iron and hemosiderin, fibrin infiltration in between the inner and outer segments of the photoreceptor, causing destructive sharing of the cells, and sharing of the outer segments. It can cause from the contraction of the blood can happen. So submacular scar formation is the ultimate reason for the poor visual prognosis. So the individual opportunity within first 2 weeks because of this extensive damage, permanent damage may happen. So usually the treatment strategy depends on the size and the duration of the hemorrhage. So usually this algorithm we are maintaining before going for any kind of vitrectomy in case of wet AMD, like it is small size less than 4 disc diameter and it is recent or less than 2 weeks. Usually pneumo displacement is enough and anti-VEGF injection is also enough. There is no need for vitrectomy. But if it is a medium size vitrectomy blood, more than 4 disc diameter, but not extending beyond the temporal vascular arcade, and usually in between 2 to 4 weeks. So usually cocktail after doing vitrectomy, cocktail of subretinal TPA, anti-VEGF, and air injection is sufficient. And if it is massive, more than 4 disc diameter extending beyond the temporal vascular arcade, so go for the either vitrectomy followed by subretinal blood removal by retinotomy, and or you can go for the 6 to 7 clock hours retinectomy, peripheral retinectomy followed by blood drainage, or you can go for blood removal, subretinal blood removal followed by RP, patch graft transplantation if it is very much long standing. So if it is small size, like in this case of my PCN, we can see the small subretinal hemorrhage. So after single injection, anti-VEGF is sufficient. So in cases of medium size blood, if it is not extending beyond the temporal vascular artery and most of the blood is inferiorly and fovea is just covered with the subretinal blood. So in these cases, vitrectomy along with this subretinal TPA, the tissue plasminogen activator, that is RTPA, and this dose is 50 microgram in 0.05 ml, usually coming in the actylized in 20 milligram in 20 ml of injection. You can just use 0.05 ml out of it. And now coming, it is a case of sub-neurosensory retinal sub-RP hemorrhage, vision photochromic close to face, we are accurate. And you can see the both are sub-neurosensory sub-RP hemorrhage. And after doing vitrectomy, I've done the PVD induction, the injecting TPA subretinal just behind the neurosensory retina, as well as sub-RP. Basically, sub-RP TPA is not advocated because of systemic absorption is more. So wait for some time. Usually, 15 to 45 minutes waiting time it is required for adequate plot lysis. Then inject subretinal anti-VEGF along with air injection. Do fluid exchange. So after this kind of intervention, you may get this kind of results. So it's a very good. Vision improves a lot, and you can see the complete complete resolution of the subretinal sub-RP blood. So coming to my second case, where there is vitreous hemorrhage and subretinal hemorrhage was incident diagnosed. You may think it is a case of post-BRP or post-diabetic, but it's diabetic post-PDR case. But still, after clearing the vitreous hemorrhage, you may detect this kind of submacular hemorrhage. Not that much. Still, the macula is almost covered with the subretinal blood. So inject subretinal TPA and just blob-like elevation in three areas. But basically, most of the blood is infraredly. So little bit of elevation is required and followed by subretinal anti-VEGF, and air is sufficient to manage this kind of cases. And post-operatively, you may get subretinal old blood infraredly, but macula is absolutely clear. You can see, except subretinal neovascular membrane is there. These are all non-drainage techniques. This is coming to my drainage techniques. Vitrectomy done, and after vitrectomy, you are injecting subretinal TPA for this massive subretinal hemorrhage. Then just did small paramacular retinotomy after waiting for 15 to 30 minutes, and you can see the subretinal clotted blood as liquefied blood is already coming out. And after adequate drainage of blood, you do the fluid exchange and do laser and all around the retinotomy sites of retinotomy. Inject some kind of anti-VEGF, whatever is available with you, and followed by silicone injection. So slowly, post-operatively vision improves. Still, after 3 months of silicone removal, vision gained ultra-binary 6/8 in vision. So coming to my another case, more extensive hemorrhagic retinal detachment. These are the more severe kind of situation. We can see behind the eye well there is totally full of blood, and this kind of blood is quite brown color because a lot of RP is released in this kind of situation. And behind the blood, you can see the totally retina is elevated and total retinal hemorrhagic retinal detachment. In this kind of situation, subretinal TPA is very good. I should say 2 to 3 quadrants of retinal TPA injection. It just lies the blood, and if you do the retinectomy or retinotomy, the blood will come out just like water. So if you have to wait it for some time. In this situation, I am doing the temporal retinectomy, 6 to 7 hours retinectomy, and remove the blood as much as possible, and trim the anti-retinal flap also. Then inject some pierce just over the retina, and do the laser all along, complete your laser, and finally you may do the siliconal PFCL exchange, injecting silicon on the left hand and removing PFCL with the right hand. So after you can see the retina is looking decent. So post-operatively, after 10 months of silicon removal, vision gained 6/36 vision after PR inaccurate situation. Now from PR inaccurate situation. Another case, hemorrhagic retinal detachment with cataract. Finally, patient gained 6/36 vision after 36 months. So now coming to the subretinal blood removal, the autologous RP chloride patch drop transplantation, where retina is not elevated, you have to create blob-like elevation of detachment, but where the retina is already elevated, like hemorrhagic retinal detachment, you can do peripheral retinectomy, temporal creating giant retina, and remove the blood, and then remove the blood all along the whole as much as possible, coming to the submacular area. And when there is flaccid neovascular membrane is detected, you have to remove it gently, especially with the ILM forceps, and finally you have to remove it and just try to remove the blood and do gentle cautery for the from the feeder vessels, and finally you can go for the RP chloride pad graft transplantation. These are meticulous surgery with the bilateral situation using Chandler's, right? Take the RP chloride pad graft transplant from the under the PFCL and remove the PFCL, and again settle the RD, and finally you may get some kind of good result out of good result. Almost I can say 50 to 60% success will be available with these around extensive surgeries. So hyphema, extensive scarring, hypotonia, recurrence of subretinal blood are some post-operative problems. You have to take care of all these situations. Thank you.
Thank you so much, Shubhendu da, for this beautiful presentation. and this is something that all of us benefit, seeing you. We'll come back to the discussion, and thank you so much. I would like to request our next speaker, again a luminary, Dr. Rupak Kanti Vishwas, who will be speaking on extra large macular holes and recurrent macular holes. Definitely not the end of the road. Welcome, Dr. Rupak.
Thank you, Dr. Devdulal, for putting me into this, star-studded session, which is all the previous surgeries was excellent by default. And I will be sharing. I think this is most of you have already seen this. Is it visible now?
Yes, yes.
Yeah. So I will be. So this is one of the most important. Treating macular hole is a day-to-day practice for a vitreoretinal surgeon. So you can once you do a normal macular hole surgery. So this is just a routine stay for all standard macular hole surgeries. This is ILM peeling of a large ILM peeling. But even after also you can land up of having the macular hole is open. So once you have a large macular hole or an extra large macular hole, so you always initially itself to prevent this kind of inverse flap technique, which is most well adopted technique. I'll be more focusing when we have a very large macular hole which cannot be covered by this. So in that situation, we can just take a free flap of ILM and then plug into it. So there are other way of handling it. The lens capsule or the amniotic membrane has also been tried in this kind of extra large or non closed holes. But then we had an idea that why not to put because all of them are actually a scar tissue. Then to see why not to put the retinal tissue there per se as such, and see how this graft is functioning. So, but as you know that retina is a continuation of the brain tissue, and the neural tissue cannot be grafted as of now. So we thought, let us try, and then we have designed a trephine and then taken a predetermined size of the trephine, which is slightly more, is 15% more than the hole size, which is a failed macular hole. This case is a failed macular hole surgery, and then you can very well see this graft, and then and it is almost unedited portion. So the grafting, the trephining portion has been done under saline, and this placement of the graft has been done under air, and this is gently tucked by silicone tip, and the whole macula, the residual fluid is taken up by a silicone tip fluid needle. And this is the donor site is now being lasered, and this is followed by fluid gas exchange. Fluid gas, I mean the exchange with this C3F8 gas. So with this procedure, then we were waiting for this result, and then we were very much thrilled to see that hole is completely closed, and you have a somehow kind of a graft tissue which is lying there, which has a little bit more similar to the retinal architecture rather than the retinal scar which I have shown you earlier. Now, if you see, this is the functional, this is the anatomical success. But what is the the functional, the ability of that graft, whether it is able to perform or not? So for that, we started performing central 10-2. And you can see it here of the same patient. You have our central 10-2 is 25 to 27 decibel of macular threshold, so which is significantly higher. And these are the this is the old record of our only initial 7 cases, and this has been started since 2014 was the first graft was done, and this is the initial 7 cases, which has a near about 3 out of 7 cases has a significant improvement of vision, especially the near vision, and the patient was able to read newspaper with that eye. So this is one of the most important part of it. Now, the most striking difference, this kind of retinal grafting has already been tried by different surgeons all over the world very recently. But again, the technique which is lying different is there. Here it is the graft which is lying over the macular hole, not actually fitting into the size. But in our cases, we are just taking them of the exact size of the macular hole and then putting into the hole, assuming and hypothesizing that there is, once you have the neural tissue in contact, they can have a aberrant regeneration between those two raw surface, and the transmission can happen. So that is probably the hypothesis behind it. And due to this, the significant amount of the macular function has been restored. This is a normal case. This is a normal macula foveal multifocal ERG. This is a case when we did ILM peeling, standard ILM peeling, and this is a case when failed. In case of failed graft, we have given this in MFERG, but this is the retinal graft tissue. You can see all of them in one page, and you can see the difference between the functional ability of the graft. Now, this is actually as Dr. Devdulal was telling, this is actually not the end of your road. So once you fail, then you start thinking of how to overcome it. And probably there are a lot of cases are needed to support this hypothesis. But again, we have done almost near about 15 cases as of now, and with a successful outcome. So these are the 3 cases, initial few cases which I'm showing it here, and probably this is the way forward. And we need to have a much more of this kind of cases doing together. The similar way we can do it for the larger size of the hole. The size you determine and then refine it accordingly, and then put the graph there. Thank you all.
Thank you so much, Dr. Rupak, for finishing in time and showing us something that's kind of out of the ordinary. So thank you, and a brilliant technique there. I will come back to the discussion. The next speaker is going to be none other than Dr. Manish Bapaye, with many innovations and many awards. I would like to welcome Dr. Manish Bapaye for his talk on intraocular foreign body removal, the best way to handle the tricky ones. Welcome, Dr. Manish.
Thank you, Devdulal. Thank you for inviting me for this talk. I seem to be the most Western person in the faculty. I'm from the west of the India. All of you guys are from east of India, so I feel like an American in the group today. Jokes apart, I would be talking about this IOFP. I'll just show 4 cases of difficult IOFP situation. Please stop me if I'm going for overshooting time. The first case is a young patient who had a injury while working in stone quarry, and he had a large scleral and limbal tear. So in the first part of the surgery, we did the scleral tear repair, and we used hand-over-hand technique to suture the sclera. On reaching the medial rectus, we disinserted the medial rectus after tagging it, and then the posterior extent of the scleral tear was sutured before the muscle was sutured back in place. Then the paracentesis was done and the hyphema was removed. It was organized hyphema. It was a couple of days old injury. Then the vitrectomy was done through limbal incisions. And as we saw in the CT scan, there was a very large stone foreign body, which was almost involving the whole of the globe. So vitrectomy was done, core vitrectomy, and the foreign body was removed, released of all its vitreous attachments. Then the sclerotomy on the right side was enlarged, and the claw forceps was used, and then the claws were protracted. The foreign body was picked up from the retinal surface, and then the limbal incision was made. It was almost 180 degrees of limbal incision before the foreign body was held by shake hand technique, and we had to use the superior rectus forceps, the largest instrument in our set, to remove this very large foreign body. Towards the as the foreign body was removed, the limbal wound was sutured, and we tried to settle the retina, but it was quite some time, and we were losing view. and PVD was not getting induced, and the patient basically was no perception of light. So surgery was, the case was closed at this particular stage. So in this case, we could lift the foreign body using the claw forceps, hold it in mid-vitreous cavity, while other hand was used to enlarge the wound and to remove the foreign body out of the hand. The second patient was again a young patient who had industrial accident while working on lathe machine, and large metal chip had entered the vitreous cavity through pars plana. It was almost like a surgical insertion. The lens was untouched. The lens was clear as we can see, and it was a very large foreign body as we saw it on the X-ray. So initially the entry wound was sutured using 80 Vicryl, and then the three-port pars plana vitrectomy was done. We can see a very large foreign body. The challenge was to get the foreign body without causing any retinal damage. So here again the vitrectomy was done to trim the foreign body from all the vitreous attachment. At this stage we did not induce the PVD. We just removed the foreign body. The vitreous attachments were released from the foreign body. Again, the sclerotomy on the left side here I was enlarged, and then since this was a metallic foreign body, we used this intraocular magnet, which is devised by Ferenc Kuhn, using the left hand, which is not non-dominant hand for me, and then it was done so as to not to drag the foreign body across the macula. This magnet is excellent and it's very powerful. Such a large foreign body, I could railroad it out of the eye without causing any retinal damage. As you know, it was carefully removed from the vitreous cavity without touching the lens or causing any retinal damage, which was a challenge in itself. As the foreign body was removed, then the PVD was induced, vitrectomy was completed, and and then the case was closed with the possible areas of retinal break were lasered. The next case is a patient who was having trauma. He had his glass broke while driving a bike, and there was organized vitreous hemorrhage. We had done CT scan and ultrasound, but could not see any foreign body intraoperatively. Or pre-operatively, I mean. Intraoperatively, after the vitreous, this was densely organized vitreous hemorrhage. So the vitrectomy was done to remove the vitreous cavity completely, remove the vitreous hemorrhage completely, and there was an incarceration site which was seen, and there was a foreign body. This was a glass foreign body. So again, I had to use the claw forceps to lift the foreign body from the retinal surface, and then it was placed on the iris before limbal incision was. So the claw was removed from the sclerotomy, and then we could I again inserted it through the limbus and removed the foreign body from the anterior chamber. The next case is a interesting case. This was a patient who was having a very tiny foreign body. It was almost not visible. It was only the CT scan. These were the only two pictures where the foreign body was seen on the CT scan. So this is kind of importance of CT scan. Even if you do not see the foreign body, ultrasound didn't pick it up because it was at pars plana. It was a very tiny foreign body, so couldn't be picked up by ultrasound. So intraoperatively, I first did the cataract surgery, put the lens, made sure that the foreign body was not there in the ciliary circus, and then went in with the sclerotomies and did the vitrectomy with PVD induction at this particular point of time, because I had to do base excision before I approached the foreign body, since the foreign body was in the inferonasal quadrant in the pars plana, in the inferonasal pars plana region, and I had to make sure that there were no vitreous attachments to the foreign body before I removed it. So here I induced PVD before, did base excision, and we can see the foreign body right here. This was released of all the vitreous attachments, and then it was held with the vitreous cutter. And we have to be careful that we are not hurting the pars plan, creating a break when there is none. And then the foreign body is pulled in the visual axis and is held with forceps with one hand. It was held with forceps in with one hand. It was taken off from the vitrectomy cutter. Then the sclerotomy on the right hand side was enlarged, and I used microcapsulorhexis forceps to get the foreign body out of the eye. The patient had very good visual acuity since there was no retinal damage. So I think to conclude, I would like to say that we have to approach these cases with detailed preoperative examination and localize the foreign body so that you can plan your surgery. You should have a surgical plan, how you are going to, touch the foreign body, or how you are going to approach the foreign body. How are you going to grasp it from the retinal surface and bring it to the site of where you are going to take it out, either through limbus or through sclerotomy. Before you approach the foreign body, make sure that you have got watertight wound closure. Complete the vitrectomy to the extent possible and release it from all the attachments to the IOFP. We have to plan the management of cataract if there is traumatic cataract or lens. If you are going to touch, if you are going to treat it before or later, the cataract part of it. And before we close, if you have not had any retinal breaks, make sure that they are not there, you have not missed any by doing thorough peripheral retinal inspection before sclerotomy closure. Thank you for giving me opportunity, Dr. Deepala.
Thank you so much, Dr. Manish. I'm sure this is something that's going to incite a lot of questions. So I will be the last speaker kind of, so I'll be sharing my screen. And I hope my presentation is visible.
Yes, yes.
Okay. So I'll be talking about resurgery. We all have our share. So I'd like to start off where Dr. Manav Jyoti Barman and Dr. Arindam actually left off. So it's very important to do a proper vitrectomy and ensure that there's a proper PVD. Like Dr. Arindam showed in a patient with recurrent vitreous hemorrhage, the PVD was not done. So I mean, it's not good if you do a vitrectomy and leave the posterior vitreous. So this is something that has to be done and has to be done every time. The other important thing is small tips to kind of avoid going in again is in pediatric RDs where you can't do a buckle, don't shy away from doing a belt buckle. Even though we do 25 gauge vitrectomy exclusively, almost I guess everybody does it. So 25 gauge or maybe 27 gauge also. So don't shy away from a belt buckle, especially if you think that this is going to be of help. There's no ego involved in this, and extra layer of support helps the patient a lot. The next thing that I would like to share is that don't shy away from draining the CDs, large choroidal detachments. This is a type of a choroidal detachment that actually needs drainage, and it's so easy nowadays. This is a slight old study with 23 gauge instruments, and so you can just make a peritomy and go in just up to the cross the sclera, and then the fluid starts coming out, and it's almost a self-draining kind of a situation where the fluid is gone from the choroid if it's a serous detachment, of course, and then you can see that the choroidal detachment is gone. So the other important thing when you are doing macular surgeries, be sure that you have stained properly. If the BBG doesn't stain, then you need to think that there's something more to it than just the ILM. So you try with trypan blue again, reti blue in this case, and so this is when you can realize that if BBG failed, there could be a ERM, and this is so evident using trypan blue. Now, moving on to resurgeries. So recurrent macular holes and large macular holes. We've seen the wonderful presentation by Dr. Rupak Biswas, but here's a different take on it. So this is a modified technique for recurrent macular holes and large macular holes. And this is something that entails mobilization of the retina and drainage of fluid from within the macular hole. So I'll just stop the, can I ask you to stop the audio, please? Yes. So this is a recurrent, macular hole. This is a speeded up video for the sake of time. So here you can see the previous surgeon had done the ILM peel, but it reopened. And so this is what we actually have done and we are doing in a lot of cases. Use the silicon tip cannula to just sort of massage the around the macular hole, and it gets converted into a slit, and then you just do a FGE, the fluid air exchange, that is, and then you drain the fluid from within the macular hole. So this actually causes closure of the hole, and this is something that we published also, and it gives you back the EZ and the ELM also with and within a couple of months. So next is talking about recurrent vitreous hemorrhage. After you've done a vitreous lavage, do ensure that the peripheral vitreous dissection has been done properly. If it has not been done, you need to do it again, and the segmentation of these fronts need to be taken care of, and you need to remove the vitreous from the periphery. And of course, you need to cauterize these properly so that there's no recurrent hemorrhage. And of course, finally followed by a laser. So a proper laser of the periphery is also essential if you need to prevent these patients from developing recurrent hemorrhage. And of course, anti-VEGF has its own role in these situations. The other important thing is, a good visualization is important in vitreoretinal surgery. So this is a case that presented with a posterior pole tractional detachment in a PDR. And this is after the first surgery. And you can see the retina is nice and flat, but in 3 months time before the silicon oil removal, this inferior tractional detachment was there, but the problem was the cataract and the non-dilating pupil. So again, can I request to stop the audio, please? So this is the phacoemulsification that was done. Can you please stop the audio?
Yes, sir.
Can you please stop the audio?
There is no any audio, sir.
So this is the peripheral detachment that was there. And then can you stop the audio, please? So you can see the space between the IOL and the peripheral pupil, and you can do the dissection. Can I request the host to kind of stop the audio, please?
Devdulalda, you can do it by clicking the audio bar. You can make it mute.
Sir,
it's not working from here. It's not working from here actually.
Okay.
So that's why I wanted.
Sir, it is from your video presentation, right, sir?
Yeah. Can you stop it, please?
No, we cannot stop it because the presentation access, you only have it with you. So in your video on the right hand side, extreme right side, see there is a audio sign there. When you play the video on the play bar,
just reduce the voice of the volume of the voice of the video from your side.
Yes, sir. That is the only option.
That is the only option.
Okay. So
we cannot do anything about it.
They cannot do anything.
Okay. So I don't know if anyway we can maybe proceed with this. So basically, this actually the peripheral dissection was done, and actually we could manage this because of the wide pupillary dilatation that was provided by the pupil expander, and finally the silicone oil was injected, and this is the BHAX that was removed. So a good visualization actually enables proper vitrectomy. So the post-operative vision was good, and this is also something that we published in the Indian Journal of Ophthalmology regarding BHAX pupil expanders, but you can use any pupil expander in this. And last but not the least, sometimes actually it is destiny that takes care of things. So this is a simple retinal detachment with a simple HST, and this is a pseudophakic eye, and a normal kind of a vitrectomy. I'll just take a minute. And so this area actually was lasered, and obviously we did a 360-degree barrage also. But the patient came back with this recurrent detachment 3 months on, and so you can see there's ERM here that we removed. But in the nasal quadrant, there was a subretinal band also which we removed. And I thought there was some extra amount of ERM that was there, so we stained this with trypan blue, and lo and behold, there was a lot of ERM that was still existing there, and so we removed that, and the retina settled well. But as luck would have it, this patient actually came back after a month, and this time with something else. This was a raised IOP because of a silicone oil bubble that was there in the AC, and it was pushing the retina. There was this it was pushing the iris rather, and there was this peripheral synechia. So we had to do the SOR, the silicone oil removal, at 1 month. And of course, following that, we actually released almost done. So we released the peripheral anterior synechia. This I am using a dumbbell here, but it's better to use a iris repositor under viscoelastic. This was done. So actually, sometimes destiny has other things in store. So even a simple detachment can have recurrence. So thank you for your kind attention. I'll stop sharing, and now I guess we have sufficient time for some discussion. So first, I would like to start with the first presenter for the day, co-instructor for the day, Dr. Manav Jyoti Burman. So what is your current choice of gauge for vitrectomy, gauge of surgery? Have you converted to 27 gauge, or are you still doing 25?
Occasionally I use 27. Mostly I go 25 only.
Okay.
Usually I prefer 25.
Any special cases where you feel 27 gauge would be beneficial?
27 only in very clean vitrectomy I am comfortable. Otherwise, most of the cases I prefer 25 only.
Okay. And you have you noticed that the 27 gauge cutters, do they last through the surgery if it's a long surgery, or do you find the need that for a change of cutter when you do a 27 gauge?
To be very honest, to be very honest, I'm not using 27 for long surgeries. Say just for taking samples, vitreous samples, are very pediatric cases. Sometimes I use 27 gauge cutters. But in general, I cannot comment the longevity of this 27 gauge cutter in general, because definitely in complicated, most of the cases we are handling are, at least to some extent, these are complicated cases, and I don't think 27 gauge cutter is very comfortable for this purpose.
What about ROP surgery? Do you feel it is an advantage?
No, ROP 27 is not at all advantageous. Yes, preferably 23 or 25 is because there are lots of membranes to cut in ROP surgery, and 25 is okay.
Okay. Thank you. The next question is to Dr. Aniruddha Maiti. Do you actually use scissors for dissection? I request all the co-instructors to feel free to ask questions and interact. So it's not a one-on-one kind of a situation. Please feel free.
As I was showing in my video, nowadays the use of forceps and scissors has come down. With the smaller gauge vitrectomies, we can dissect most of the membranes, but yes, in few cases we do require bimanual dissections.
Okay. Do you still use the scissors that we used to use a long time back? And
yeah, that's what I was telling. In the bimanual dissection, we are doing much less. So whenever we do it, then we use the scissors. Otherwise, with the small gauge vitrectomy, with the cutter itself, most of the work has been done. In fact, the work of the scissors is also been done by the vitrectomy cutter.
Yeah, and the other thing is, you mentioned about PFCL. Do you feel or have you noticed PFCL going subretinal in certain situations in combined retinal detachments? Lots of breaks.
We don't use PFCL only in cases where the dissection, as I was showing in the combined RD, it was very difficult to do the peripheral dissection. So to stabilize the posterior pole, we had given a small bubble of PFCL. Otherwise, mostly we don't give PFCL in these kind of cases, other than if it is not a JRT or a recurrent RD or a funnel RD. But otherwise, don't use much of a PFCL.
Okay. And
I did have a problem with PFCL just before the March lockdown. I think 2019 end. The mistake was not using a valved cannula. So because of the non-valved cannula, the fluid came in at a rush, and the PFCL broke up into so many small bubbles. It was a simple RD. So unfortunately, one small bubble, it went through the retinotomy and ended up subretinal. And sadly, it was, I mean, the location of the bubble was not in the macula, but this patient developed a macular hole post-operatively. Although the retina settled nicely, but the bubble going, the cause of the bubble entering was the breaking up into multiple smaller bubbles, and that was because of the non-use of the valved cannula. The valved cannula would have prevented that. So always when we don't use, we are not using valved cannula, the fluid should be immediately put, or I mean, it should be clamped. That was a mistake which happened.
right, I think you've brought in a very important point and pertinent point. Sometimes we are, kind of the assistant is rather reluctant or hasn't taken care to clamp the infusion or stop the infusion. The other issue also is that sometimes we in fact are not using valved cannulas. But if you have a subretinal or subfoveal PFCL bubble, anybody has a take on what is the best way to remove? Any personal experience? A subfoveal PFCL bubble?
Nowadays, I am using 38 gauge cannula for direct aspiration through the macula, fovea.
Is it a passive aspiration or an active aspiration?
By VFC.
Okay, okay. So you go straight in and
water inside a VFC. Then the sometimes people have just fill the whole vitreous cavity with the PFCL, and then PFCL somehow they pass
the PFCL away from the posterior.
That is a very mystery kind of situation. But I am in very much favor of a direct aspiration of subfoveal PFCL. That's what I'm recently doing by 38 gauge. Planning to publish that a lot of times is required to write down the paper.
And do you, when you finish these cases, do you use C3F8 or SF6?
Only SF6, sorry. Only SF6. Even
only
AR
SF6.
is sufficient.
AR is also good enough. Okay. The one question that I had in my mind for Dr. Arindam is, you showed some beautiful ultrasonographies, B scans. So are you in favor of doing a B scan on the day of surgery, or you are good to go with a B scan that has been done previously? And what is your kind of cutoff that this patient has the B scan done this many days or weeks back and I can still proceed? Is there a thumb rule that you follow?
Not on the day of surgery, but at least in the week, within the week before the surgery. Yes, definitely. It should not be older than a week. I prefer to do in the week preceding the surgery.
Absolutely. And what's your take on pre-op anti-VEGF or intra-op anti-VEGF?
Yes, we do use a lot of pre-op anti-VEGFs, especially in this PDRs with TRDs and fibrovascular proliferations. It does reduce your surgical time, and it does reduce your risk of intra-op bleeding. So I generally use it at least, I keep a gap of usually 3 or 4 days between the anti-VEGF and the surgery, not more than that.
Okay. And anybody, is allowing a greater gap, maybe 7-10 days? Is it okay to inject and then?
We generally plan within 3 days, but many a times actually patient lands up in 7 days.
Yeah, that's true.
Due to logistic issues. So yes, 7 days.
Right. And Dr. Shubhendu Boral, may I ask you to elaborate on your technique of injecting, triamcinolone for the edges of, relaxing retinotomies, and
Previously, what I used to do after doing the fluid exchange, I'm injecting the removing the supernatant fluid of the triamcinolone. We are leaving behind the triamcinolone crystals behind that beneath it, and just leaving this, injecting these triamcinolone crystals directly over the sides of RR after doing fluid exchange and laser. So, and then injecting silicone oil. Nowadays, I am just injecting silicone oil. After injection of silicone oil, using this soft tip cannula, I'm just going beneath the silicone oil, touching this tip of the silicone oil, touching this tip of this soft tipped cannula over the sites of BRRP choroid complex, then injecting the triamcinolone acetone crystals directly overlaying the RP. So the triamcinolone crystals will be sandwiched between the BRRP choroid complex and the oil. So that will act as a localized give the localized anti-PVR effect. That will control the oozing, blood oozing also, and also control the inflammation. That is the need us for the PVR changes. So that will not cause any kind of secondary glaucoma. If you leave the triamcinolone in between oil and BRRP choroid complex, that will don't cause the
Doesn't it dislodge?
The particles may come anteriorly. If it is phakic case, it may come behind the lens, but that will go away after a few weeks. That is my oxygen in any case, in the cases of PVR.
Okay. Dr. Aniruddha, you had a question?
No, I was just asking whether this doesn't it dislodge when you give it. The next day, do you see it in the position, or does it dislodge at times?
No, dislodge it may go subretinally also, but doesn't create any kind of problem.
And what is the result on giving it or not giving it?
Giving it, not giving it, I have compared in my 360-degree RR cases that I have presented in last ASRS.
So
that is like the chances of recurrent RD is quite less. Although the this is one take home, very important take home, and chance of you can do silicone removal more frequently if you are using the triamcinolone, because the like hypotony is occurring less, or the propensity to remove silicone oil, it is more in TA group.
Okay. Yeah, please.
I have one question to Dr. Baral. That algorithm you are showing in your presentation, is it your own algorithm, or is it a published one?
No, it's not a published one, but some kind of hints are there in survey ophthalmology. That was in published in survey ophthalmology, because
that algorithm
any
specific
please tell me.
Yeah, no, specific disc diameter and all these things, you have designed it yourself?
No, not myself. It is in the survey, like if it is less than 1 disc diameter, you should not call it submacular hemorrhage.
Okay.
So if it is more than 1 disc diameter, if it is less than 4 disc diameter, this it is not my own algorithm. It is there in the survey. I will send you the link.
Fine.
Okay.
But somehow some kind of modification is there by me. It's from my own experience.
Right. So I think all of us will stand to benefit with this algorithm.
Yes, definitely.
Yeah. So
I have kept it with me.
yeah.
Without permission, of course. Without permission.
No, I think you have his permission. Dr. Rupak, are you doing this new kind of technique for large macular holes as in treatment naive large macular holes, if I may call it that way, or only in recurrent cases?
As of now, it has been restricted to the recurrent cases also, but it can be tried for the larger macular hole. The only the difficulty for this is because you need to you are trephining. It is not a free flap cutting technique. So because it is a trefine, so the trefine has to go inside, and as you are here the dictum is you are increasing the size of around 1500. So suppose if you get a 1000 size of macular hole, then almost like 1200 micron size of trefine you need to go, which is 1.2 millimeter, and that is quite large. So you need to have a very large retinotomy, the sclerotomy site. So the practical difficulty in those kind of cases is that if you go with that kind of large sclerotomy and then you trefine it, but when you are doing a fluid air exchange, then that starts leaking. So then it becomes a little difficult, because after that either you will use 23 or maximum 20 gauge forceps. So even if you close it also, it is difficult. So usually I restrict it to maximum of near about 800 size of macular hole.
And how do you exactly measure what, I mean, the trephine size? Like, how do you exactly measure that this should be the size? Is it only on the OCT caliper?
No, trephine size or the OCT, the whole size you are talking about.
The trephine size. How do you
Trephine
design?
size is already,
Yeah.
it is predetermined and measured. It no, it has been engraved over there.
Okay.
So you know what is the size of it.
Okay.
So you have a different series starting from 400 to 1000 size of series is there.
Yeah, that is what I was wondering, that if you have something beyond, then obviously you will need a bigger trephine. So you will have to.
That is a little difficult to do. That is the only hurdle you have, because your sclerotomy size is larger. Even if you can suture the sclerotomy side, but even if you start suturing, but if it is very large, then it does not have that much of sealing capacity. So it tends to leak always. So in that situation, taking it and placing it into that area becoming difficult. But yes, you can try. There is no harm in that.
Have you used glue in a macro?
No. Okay. No, not yet.
So,
not yet, because that is the reason I have written it there. No LPFC or not even the silicone oil also I have used it there, so that there should not be any hindrance between these two. So this is a different, little bit different from other techniques.
Right. I see Dr. Manish.
I request all of you to use it, and then only we can have it.
Absolutely.
Dr. Bodal.
How to prevent this subretinal migration of the graft?
That is, subretinal migration is only if you have a smaller size. I'm telling you, initial first 2 cases, I had a subretinal macrohole because that time I have used only the same size of the graft. So if you have increase of a 15% of the increase, then I did not have any subretinal macros. I have a lost graft in 1 case, but again, that was intraoperatively, and then I had to regraft and then put it there.
How to get chokers from you?
How to get?
Trephines from you.
That is free of cost.
You order. We will supply to you.
Just send it to me.
Okay. I'll quickly get in, Dr. Manish. What next, Dr. Manish? What more innovation and what next? Beyond the scope of the presentation.
Nothing new actually. We have been thinking of a couple of things, but it's availability of I think the travel restrictions, that is one of the main problems. Getting ideas across. You meet in physical conferences. The topics come up. People give ideas. You can come up with solutions. You can talk to people who are working in trade who help you with this. Like from Epsilon, these people they have made both of my instruments actually. So. That's kind of missing. So we are all missing the physical get-togethers and physical conferences. It's not just jokes and catching up. It's also about all these exchange of ideas that make us rich in our clinical work, day-to-day work.
Absolutely. How do you actually enlarge the sclerotomies? Do you go in with a 20 gauge MVR, or do you have a fixed kind of a thought process on it? 20 gauge MVR. So obviously, like you remove the sclerotomy ports and then you going through the same area, or you select a different area for the
actually you can do that. I have whenever I have used the same sclerotomy, but there are a lot of other surgeons who are using forceps, who are using claw forceps. They make additional sclerotomy at 12 o'clock position, like Dr. Natarajan, where he has extensively used it for removal of pellets in Kashmir victims. So he makes additional sclerotomy. I know Dr. Sangeet Mittal from Haryana, he makes from Punjab, he makes additional sclerotomy. So making additional sclerotomy actually is a good idea. And for a large foreign body, I think that should be done, because that leaves your first sclerotomy intact and doesn't really leak. You can suture the additional sclerotomy tight and have watertight closure. If you're in 2 cases or some few cases that I've done with forceps, because these forceps is very required in very select situations, but those are the situations where you have to have it, where I enlarge my initial sclerotomy, I think it would be a better idea to make additional sclerotomy to remove such foreign words.
I think, thank you so much. I think we are towards the end of our time limit. So I'd like to really thank all of you for having participated so nicely and clearing up so many doubts. I wish this was an interaction that was possible with the audience also, but unfortunately we'll have to wait for that for another day. And thank you so much. I would like to request the hall coordinator to kind of get in.
Yes, sir.
Yeah.
Thank you, Dr.
Thank you so
Chakraborty.
much.
Though it was a lengthy session, but I'm sure it was full of interesting topics, exchange of new ideas, and everybody has gained a lot of things out from here. So I would like to once again thank all the speakers who were there for this session. Thank you so very much for attending this. Thank